Welcome to this American Journal of Managed Care peer exchange, Reducing Cardiovascular Mortality in Patients with Type 2 Diabetes Mellitus. My name is Dr. Dennis Scanlon, and I'm Professor of Health Policy and Administration and Director for the Center for Healthcare Policy and Research in the College of Health and Human Development at the Pennsylvania State University. In today's video program, Dr. Zachary Bloomgarden, Robert Gabbay, Michael Gardner, and John Johnson will share insight on the relationship between cardiovascular events and type 2 diabetes, specifically its effect on treatment selection and the management of patients' glycemic control. Today, we will also review the latest data from key trials that has revealed new findings in cardiovascular outcomes in type 2 diabetes mellitus that affect various stakeholders in the field. Before we begin, let me introduce each of our expert panelists. Dr. Zachary Bloomgarden is a clinical professor in the Department of Medicine at the Icahn School of Medicine at Mount Sinai in New York, New York. He is also the editor of the Journal of Diabetes. Dr. Michael Gardner is a medical director for the Cosmopolitan International Diabetes and Endocrinology Center at the University of Missouri in Columbia, Missouri. And Dr. John Johnson, who is Senior Medical Director with WellCare Health Plans, Inc. in Atlanta, Georgia. Dr. Robert Gabbay is the Chief Medical Officer and Senior Vice President of Joslin Diabetes Center in Boston, Massachusetts. So thank you, gentlemen, for joining us, and why don't we get started? So I wanted to start with sort of an overview of the diabetes epidemic, both its incidence and prevalence and how it's affecting you all in practice. The American Diabetes Association estimates that more than 29 million Americans have diabetes, and more than 95% of them have type 2 diabetes. The CDC also reports that the incidence or new cases of diabetes may have declined, although, Zach, I know in our earlier discussion you're not quite sure that that evidence is so clear.
Right. So there's been a tremendous growth in diabetes over the past 2 or 3 decades in the United States and worldwide, going from approximately 4% of the population to the current level of around 9% of the population of the United States, and essentially tracking with the growth in obesity in the US population. Now, over the past year or two, the level may be flattening out, although it's hard to tell, and certainly worldwide it's not flattening out. The latest IDF information from the International Diabetes Federation shows an increase from about 380 million to 420 million people worldwide. So we can see that the factors that underlie the epidemic of this paradigm of non-communicable diseases are still there. It's lack of physical activity, excess nutrition, everything that is leading to a variety of other disorders, lipids, blood pressure, and so on.
Mm-hmm. Great. We also talk about prediabetes, and there's estimates of millions of patients in the population with prediabetes. Any thoughts on sort of what we're doing in addressing that population? And when we think of prevention, sort of preventing people from getting to diagnosed stage 2 type diabetes, how have we been doing?
Well, I'd have to say we're not doing very well because, as was just mentioned, the incidence continues to increase, the prevalence continues to increase. There have been some exciting things coming out with the DPP and the actual implementation of that relatively old study, and funding for it through Medicare now, I think, is going to possibly help to turn this trend a little bit.
Yeah, I mean, I would also say, though, that for better or worse, I don't think there's been a public recognition of the seriousness of prediabetes and how it leads to diabetes. And even that term prediabetes is not uniformly known by everybody in the public. And so I think we still have work to do from an awareness perspective. And then I think, as was mentioned, programs that we know can prevent the development of diabetes are available, and we need to make them more widespread.
Mm-hmm. So, we talked earlier, there are relatively few endocrinologists relative to primary care providers who are the bulk of the professionals treating this illness. What's going on in terms of primary care, in terms of addressing this, and are we making the strides we need to make? I know, John, you deal with lots of clinicians in your role as a payer.
What we've seen in the United States is there's approximately 5,000 endocrinologists, and we're seeing that diabetes is being managed more by the primary care community. And so as guidelines are being made available to the primary care providers, they're expected to lean forward and assist with care of these patients.
So we talked about, somebody mentioned the Medicare payment for the diabetes prevention program. I'm hearing kind of mixed thoughts on that in terms of both the reimbursement and the potential impact of the program. Wondering if any of you have some thoughts on how that's playing out.
So the dilemma is that we've all known for decades that physical activity and healthy diet will prevent the development of diabetes, and the diabetes prevention program that Michael mentioned, the DPP, absolutely showed that actually it's better than medication in preventing development of diabetes. But delivering that intervention is tremendously difficult, and it requires a high level of interaction between healthcare providers, not necessarily tremendously trained, but individuals who will encourage people to eat right and exercise right, and getting that daily exercise, walking the 10,000 steps, limiting your diet, is just very hard for many people to do.
And I think that's very important what Zach just said, is that the DPP, the successful intervention, was much more intensive than what many of us are able to do in our offices and in our clinics. And that's what I think is so exciting about the program that the YMCA has been bringing out across the country and now is being picked up by Medicare, is that they are bringing into the community level and having trained community volunteers to reach out to their peers, their friends in the community, and bring these more intensive interventions and this support network to achieve the 7% weight loss that was seen in the DPP.
And I think this is where the managed care community can step in and partner with the providers and community resources to create a social safety network for diabetics. For example, so much of diabetes education and awareness occurs outside of the presence of the provider, such that nurses, social workers play a major part in nutrition, diet counseling, and carb counting. And so there's more that the managed care community, particularly at WellCare, that we're leaning forward to help our providers and help our members do more of a patient-centered approach to care.
And even non-professionals can really play a role. So many years ago, I was visiting South Africa giving talks, and I went to a clinic where a group of volunteers, totally non-healthcare professionals, had set up essentially a gym and a teaching themselves how to eat properly. They had great interest in the community, and they were very excited about it, and I'm sure they were doing a great job.
Sure, yeah. I mean, fundamentally, because of the scope of prediabetes being more than 80 million people, it has to happen at the community level. I mean, the healthcare system alone can't absorb that. And honestly, I don't think the role of the physician is that great in all of this, other than endorsing the work and doing the warm handoff to the kinds of programs that are effective. But most of these programs are effective without physicians being involved. It's community people that can be trained by organizations to deliver this kind of work.
Exactly.
And that to get that many people, the healthcare system can't handle that.
And to go where the people are.
Right.
Yeah, right.
That's the
Exactly.
other key,
right. Because
of this
it's a
program.
weekly or bi-weekly program. I mean, yeah.
But I think physicians being in front of the patient and
Sure.
driving the care
Endorsing it.
can
Endorsing,
endorse
yes.
those resources in a
Absolutely.
way that the patients will be more likely to engage it.
Absolutely.
And I think what we've seen is the utilization of these care management, disease management resources are very limited because there's still not an increased awareness about them.